All right, the first few vignettes we're going to see on neck trauma are penetrating trauma to the neck. We made the point a little earlier that most penetrating trauma, we end up operating the patient to repair injuries. But let me try to be now a little more specific and give you first what are the absolute indications to pick the answer that says go to the operating room. Okay? This would be any penetrating injury of the neck where the patient is rapidly deteriorating. So whether it happens to be a gunshot wound or a stab wound, if the vignette says blood pressure is going down, not responding to fluids, the patient is dying, then the only answer is run to the operating room and open the neck and try to stop what's going on. There is a second pretty much absolute indication. All gunshot wounds to the middle part of the neck end up in the operating room. That particular location in the neck is crammed with important structures that shouldn't have holes in them. And if we have a gunshot wound to that part of the neck, the middle zone, we always have to operate. We also have to operate clearly on any penetrating injury of the neck where there is evidence of injury of an important organ. For instance, if a vignette says there is a big expanding hematoma, well, that's obviously coming from a big blood vessel that will need to be repaired. The vignette might say the patient is spitting up blood, coughing up blood. Well, there's been an injury to the tracheobronchial tree or to the esophagus. So that's another reason. However, if we're giving a vignette that is a stab wound to the neck, we really have to look then, is there evidence of injury like I just described? Because otherwise the stab wound to the neck has more flexibility on the management than the gunshot wound. Okay? With that little background, let's begin to read the vignettes, and we'll now see the various examples. Vignette number 15. A man has been shot in the neck and his blood pressure is rapidly deteriorating. There is only one answer here, and that's rush to the operating room. All right? Easy. Vignette number 16. A 42-year-old man is shot once with a .22 caliber revolver. The entrance wound is in the anterior left side of the neck at the level of the thyroid cartilage. X-rays show that the bullet is embedded in the right scalene muscle. He is spitting and coughing up blood and has an expanding hematoma under the entrance wound. His blood pressure responded promptly to fluid administration, and he has remained stable. And we can see in this vignette 3 clear indications that this patient needs to go to the operating room. The first one is he has a gunshot wound to that middle part of the neck. We already agreed that's one reason. We're also told he has an expanding hematoma under the entrance wound. Well, that's another reason. And we're also told that he's spitting and coughing up blood. So there is no question. The only correct answer here is go to the operating room, explore the neck. He doesn't have the fourth one that we exemplified on the previous one. His blood pressure is actually responding and he's stable, but he still ends up in the operating room. Now let's begin to look at the exceptions. Number 17, a young man is shot in the upper part of the neck. Evaluation of the entrance and exit wounds indicates that the trajectory is all above the level of the angle of the mandible. A steady trickle of blood flows from both wounds and does not seem to respond to local pressure. The patient is drunk and combative but seems to be otherwise stable. Now we have the uppermost part of the neck. You know, that's not very friendly surgical territory. Even though we surgeons like to think that we can solve any problems anywhere, all we have to do is get in there. When we deal with vascular injuries, there is an essential concept that the first thing we have to do in a vascular injury is gain proximal and distal control before we go to where the injury is. This high in the neck, with the base of the skull right there, it's very difficult to get that proximal and distal control. We can get the proximal one, but the distal is inside the head. And so we would rather not operate in this area. Fortunately, this area doesn't pose a problem with our aerodigestive tract. It's too high. So a gunshot wound at that level, we don't have to worry about the esophagus and the trachea being injured. The only thing we have to worry about is a major vascular injury. So we prefer to deal with this one, if at all possible, by angiographic means. In other words, we would prefer that what we do here is an emergency angiogram. The angiogram, the arteriogram, identifies the injuries and then hopefully allows the radiologist to embolize the bleeding vessels and stop the bleeding in that fashion. Let's go to another exception. Vignette number 18. A young man suffers a gunshot wound to the base of his neck. The entrance and exit wounds are above the clavicles but below the cricoid cartilage. He's hemodynamically stable. Well, this is a gunshot wound to an area of the body that is full of vital structures. We are going to want to operate on this young man. But if at all possible, we like to do every diagnostic study we can before we operate. Because the base of the neck is one of those boundary areas. It's the lower neck, it's also the upper chest. And the surgical approach may in fact be quite different depending on where exactly are the injuries. So if at all possible, we like to do an arteriogram on this patient. We like to do an esophagogram. We like to do an esophagoscopy. We like to do a bronchoscopy. And then we can determine whether we can operate through the neck, whether we need to do a medium sternotomy, whether we need to do both neck and perhaps a upper chest exposure as well. We need to know where to put our incision, what surgical approach to use, and therefore, if at all possible, we want those studies. Now we're going to move to the stab wounds. Vignette number 19. In the course of a bar fight, a young man is stabbed once in the neck. The entrance wound is in front of the sternomastoid muscle on the right, at the level of the thyroid cartilage. The patient is completely asymptomatic and his vital signs are completely normal. This is one that we can just observe clinically and see how he does. Now, if we had been told his blood pressure was deteriorating, we would have needed to operate. If we had been told he had an expanding hematoma, we would have needed to operate. If we had been told he was spitting up blood, coughing up blood, we would have had to operate. But with a stab wound that is completely asymptomatic, even when it is in this middle of the neck, that had it been a gunshot wound, we would have wanted to operate. We can then have a more flexible approach. All right, let's talk about blunt trauma to the neck. Year number 20. A patient who was the unbelted right front seat passenger in a car flies through the windshield when the car crashes into a telephone pole at 30 miles an hour. He arrives in the ER strapped to a headboard and with sandbags on both sides of the neck. He has multiple facial lacerations but is otherwise stable. Examination of the neck reveals persistent pain and tenderness to palpation over the posterior midline of the neck. Neurological exam is normal. If somebody flies through the windshield, sustains this kind of trauma, and then says, my neck hurts here, we have every reason to believe he may have a bony injury to the cervical spine, but we're told that he's neurologically intact, and that in fact is the critical example. If we had been given the same identical vignette, and we've been told the patient is quadriplegic, well, there isn't that much now that you can do, that you can show in the exam that you understand what the problem is, because the problem is already irreversible, probably. But in this particular situation, where the patient still is neurologically intact, but saying it hurts here, and you know that the mechanism of injury could very well have damaged the cervical spine, this is the one where your answer has to be to look at that cervical spine before anything else is done. And this would mean either the cervical spine x-rays, AP and lateral, including the odontoid views, including from C1 to the first thoracic vertebra. Or if you had reason to do a CT scan of the head, you could extend it to include the neck. Or I might add, if you have no reason for scanning the head, you do this cervical spine X-rays and they are equivocal and the patient is still saying it hurts there. You actually might want to do a CT scan of the neck, because that's actually a more reliable way to look at C-spine injuries than the old X-rays are. Well, we've been talking about spinal cord injury. We may, in fact, encounter some questions on the exam where spinal cord injuries are the subject. Let me give you a little background as to how these might come about. I gave you earlier, told you that the emphasis on the questions is either very common or very high impact conditions. Now, there is another potential reason for a question being on the exam. If a very important principle of basic sciences finds expression in a clinical situation, it makes for a good bridge between step 1 and step 2. And so we may find questions in step 1 that are adorned with a clinical flavor, and we may find questions in step 2 that are a clinical situation, or there is an underlying basic science principle. Anatomy is a good example of that. And spinal cord injuries are an excellent way to demonstrate that you know the anatomy of the spinal cord. And obviously in that context then, the question will not be a complete transection of a spinal cord, because that one is too easy. Nothing works below the level. But the various syndromes of incomplete damage to the spinal cord are excellent ways to test for anatomical knowledge. Let's read vignette number 21. An 18-year-old street fighter gets stabbed in the back just to the right side of the midline. He has paralysis and loss of proprioception distal to the injury on the right side, and loss of pain perception distal to the injury on the left side. Now, if you remember all the anatomy of all the tracts in the spinal cord, you should recognize that this is a hemisection of a spinal cord, the famous Brown-Sequard syndrome. But even if you don't remember the anatomy in detail, you should still be able to identify it, because there are two clues here. One is there is one set of functions that is interrupted on one side and a different set of functions that is interrupted on the other. Anytime you see that, you know it's a hemisection. But in addition to that, the only way to get a hemisection is with a clean cut. You know, the patient who jumps from a diving board into the shallow end of a pool and ends up with a spinal cord injury, he doesn't end up with a hemisection. Hemisection requires that clean cut. So when you began reading this vignette and you read that the patient came in with a knife sticking out of his back or his neck, you already know this is going to be a hemisection. And then you see it because you have one set of functions on one side, a different set of functions on the other. Vignette number 22. A patient involved in a car accident sustains a burst fracture of the vertebral bodies. He develops loss of motor function and loss of pain and temperature sensation on both sides distal to the injury, while showing preservation of vibratory sense and position. Now, even if you don't remember an awful lot of spinal cord anatomy, you should remember that the spinal cord is behind the vertebral bodies. So if a mechanism of injury, something happened to vertebral bodies, the part of a spinal cord that will get damaged is the anterior part. You should also remember that vibratory sense and positional sense travel in the most posterior part of the cord. So this is an anterior cord syndrome. Let me point out, incidentally, that the anterior cord syndrome can also be seen in vascular injuries of the vascular supply of the spinal cord, because it comes from the front. Okay. Vignette number 23, an elderly man is involved in a rear-end automobile collision in which he hyperextends his neck. He develops paralysis and burning pain on both upper extremities while maintaining good motor function in his legs. This one is a central cord syndrome. Two things identified. The mechanism of injury was a hyperextension. And the other thing is this rather bizarre situation where the arms are in deep trouble, but the legs are still working relatively well. This doesn't make sense. If you think the brain is up here, the nerves go down this way, how could you still have nerves reaching the leg if they are not reaching the arms? Well, the reason is the way the fibers are in the bundles, and the ones that are closer to the center happen to be the ones that go to the arms. So this one is the central cord issue. Let me repeat the three spinal cord syndromes. If there is a knife sticking out of the back, something doesn't work on one side, a different set of function doesn't work on the other, that's hemisection. If there's a blowout of a vertebral body, the only thing left working is vibratory and positional sense, that's the anterior cord syndrome. If the mechanism is hyperextension, the arms are severely damaged, the legs are still relatively intact, that is the central cord lesion. Now, what about management for any of these? Probably too complex for step 2. Let me reassure you, incidentally, that step 2 was not an exam designed for neurosurgeons and their boards or for, orthopedic surgeons or general surgeons. It was designed actually for fourth-year medical students. So these are relatively elemental levels of information that are needed, and all the intricate detail of how to handle a damaged spinal cord are not required. You should know, though, that the best way to look at the spinal cord is with MRIs. Now, obviously, all of these patients will get X-rays first. And probably the X-ray would already be in the vignette, the X-ray of the neck or whatever. But if we're then pressed, what would be the best way to see the spinal cord, the degree of damage to it? It would be with an MRI. And one little additional detail. There is some evidence that high-dose steroids, if given as soon as possible after the injury, may end up with a better outcome for the patient than if it hadn't been done. So you may find that answer in your question as the first thing you do before the neurosurgeons or the orthopedic surgeons get involved. All right, let's move on now to chest trauma. I need a little introduction to chest trauma. I have been mentioning so far that penetrating trauma and blunt trauma are two very different things. But in the case of the chest, there's a little bit of an overlap, a little bit of a blending of the two in two ways. One is that there are a number of conditions that happen when there is penetration to the chest in the standard way. A gunshot wound, a stab wound, an ice pick. But almost every one of those things that we see with gunshot wounds, that we see with the stab wounds, we could also see with blunt trauma. Because when you have severe blunt trauma to the chest and you get many broken ribs, the jagged edges of the broken ribs can be driven in by the trauma and become, in essence, penetrating weapons. And so that clear distinction between what blunt trauma produces on one hand, what penetrating trauma produces on the other, we may not see it in the chest. The second exception has to do with the management. I mentioned that in most parts of the body, penetrating trauma requires operative intervention to repair the injuries. In the chest, in fact, it very seldom does. All right? Let's go ahead and begin reading the vignettes. Vignette number 1. A 75-year-old man sleeps and falls at home, hitting his right chest wall against the kitchen counter. He has an area of exquisite pain to direct palpation over the 7th rib at the level of the anterior axillary line. Chest X-ray confirms the presence of a rib fracture with no other abnormal findings. A rib fracture, first of all, is the most common blunt injury that we see in the chest, and we have a tendency to think of it as a relatively trivial injury. And in a young, healthy person, it is a relatively trivial injury. In a 75-year-old man, it can be, in fact, deadly. And the way it would kill the patient is it hurts when you breathe. You cannot expand that chest. You avoid, therefore, breathing. You get atelectasis, you get pneumonia, and that's what kills that old man. So the answer for this vignette, for the management, we need to take away that pain, but in a way that doesn't interfere with the patient breathing. Don't pick the answer where you bind the chest. That's an effective way of eliminating the pain. You bind tightly the chest and you cannot breathe anymore and it doesn't hurt anymore. But the patient is going to get the atelectasis and the pneumonia. Don't pick the answer either where you give him so much narcotic medication, you take away the pain because you take away his respiratory drive as well. So the correct answer here is a local block. The correct answer is a local anesthetic, a nerve block that takes away the pain where the fracture rib is, but still enables the patient to breathe. All right, let's move on. Vignette number 2. A 25-year-old man is stabbed in the right chest. He's moderately short of breath and has stable vital signs. There are no breath sounds on the right, and that's hyperresonant to percussion. Well, this is a penetrating injury. There are no breath sounds on one side. It sounds like a drum when you percuss. This is clearly a pneumothorax, the most common thing that happens with penetrating injuries to the pleural space. But let me emphasize that this is a plain pneumothorax. This is not the tension pneumothorax we reviewed earlier. And the tension pneumothorax we reviewed early, air was getting into the pleural space that then couldn't get out. With every breath the patient took, more air was added. High pressure developed that pushed the mediastinum to the side, and that patient was in shock and dying. This isn't happening here. This is just air in the pleural space. A collapsed lung and, moderate short of breath. But let's read the vignette again. Stable vital signs. So the first thing you want in this patient is a chest X-ray. And I have to point that out because on the previous one, and the one with the tension pneumothorax, I admonish you not to pick the answer where you got a chest X-ray or blood gases because you had to save the life of that patient. This patient has time. Okay? So you start with a chest X-ray. It's going to show that there is a pneumothorax. And then again, there is no need here to rush first with a needle and then with a chest tube. The next thing after the chest X-ray will be the chest tube. And the chest tube, if I ask you where, if we're going for a pneumothorax, we put it high, second intercostal space in the front of the chest. All right, vignette number 3. A 25-year-old man is stabbed in the right chest. He's moderately short of breath, has stable vital signs. No breath sounds at the base on the right chest, faint distal breath sounds at the apex, dull to percussion at the base. This is a good example of an exam question that may in fact, give you physical findings that we may or may not be good enough clinicians to detect. But at any rate, if you have a penetrating injury and rather than having complete absence of breath sounds and a chest that sounds like a drum when you percuss, you have the breathing sounds gone only at the base and it's dull there, then you probably have blood rather than air. And so this would be clinically suggestive of a hemothorax rather than a pneumothorax. Now, what do we do about it? Well, let's start with the chest X-ray again. We don't have here a patient that is dying. So chest X-ray will confirm that the gentleman indeed has a hemothorax. And now comes the interesting part. What are we going to do about it? Let me give you a little background. Let's go into some baseline information. Most patients that bleed into a pleural space from a penetrating injury are bleeding from the lung, because the lung is the biggest target that one could hit when getting into the chest. And so that bleeding comes from a low pressure circuit. This is not blood coming out of the left ventricle at 120 millimeters of mercury. This is blood coming out of the right ventricle at 30 or 35. And furthermore, when the lung is injured, it tends to collapse. Bottom line is that the bleeding usually stops by itself. We very seldom have to operate a patient to stop the bleeding when a penetrating injury has produced a hemothorax. But that doesn't mean we don't have to do anything, because having blood in the pleural cavity, contaminated blood, and this one is contaminated, there was a knife that got in there. Having contaminated blood in the pleural cavity is an invitation for that blood to become infected, for an empyema to develop, and an empyema is a very bad condition. So trauma surgeons and thoracic surgeons are very compulsive about evacuating all that blood from the pleural space, which they will do with chest tubes, one or more. So again, the answer for this vignette in terms of a therapy after we've done the chest x-ray is going to be chest tube. In the case of the pneumothorax, we put it preferentially at the top, in the front. In the case of the hemothorax, it'll be at the base, lower down on the side. But again, we need the chest tube to evacuate the blood. When that chest tube goes in, though, that chest tube will provide us also with very valuable diagnostic information, because you have to realize that even though the lung is the biggest target, it's not the only target. And the patient could in fact be bleeding from something that bleeds far more vigorously than the lung does. Let's go to the next vignette or two. Vignette number 4. A 25-year-old man is stabbed in the right chest. Is moderately short of breath, has stable vital signs. No breath sounds on at the base in the right chest. Faint distant breath sounds at the apex. Is dull to percussion at the base. We assume here a chest x-ray has been taken, and now we're told a chest tube placed at the right pleural base recovers 120 cc's of blood, drains another 20 cc's in the next hour. 120 cc's of blood is not an enormous amount of blood, and 10 cc's the next hour is even less. So this confirms the fact that the blood is indeed coming from the lung. It's a small amount. It's already beginning to quit. All we need here is that chest tube. Let's look at the next one. Vignette number 5. A 25-year-old man is stabbed in the right chest. He's moderately short of breath, has blood pressure 95/70. There is a clue there already. That's a little bit on the edge. A pulse rate of 100. No breath sounds are heard over the right chest, which is dull to percussion. A chest tube placed at the right pleural base recovers 1,250 cc's of blood. Now that's a ton of blood. That's not the amount of blood we expect to see from a small parenchymal lung injury. This patient is bleeding from a systemic vessel. In fact, the systemic vessel more commonly is an intercostal, right there where that knife went in. But the presence of this much blood says to us we have to go in and stop it. So the correct answer on this gentleman, after we realize that he's bleeding that much, is he needs a thoracotomy for control of the bleeding site. And every time we make this decision, a small amount of blood doesn't require a thoracotomy, a big amount does. There is always that need to know where is the dividing line. Actually, I've read different dividing lines in the literature that deals with this. Some people say 1,000 cc's is a good dividing line. Some people say 1,500 cc's. I think to be safe on the exam, if it's over 1,000 cc's, we ought to be thinking that a thoracotomy is the thing to do, as it was here. But we could encounter that evidence of being a systemic vessel in a different way. It could be that we don't get that much blood to begin with, but on the other hand, it keeps draining at a pretty big clip. Let's read vignette number 6. A 25-year-old man is stabbed in the right chest. He's moderately short of breath, has stable vital signs, no breath sounds at the base on the right chest, faint distant breath sounds at the apex, dull to percussion at the base. A chest tube placed at the right pleural base recovers 350 cc's of blood. Let me stop right there, because with that, no one would be jumping to the operating room. 350 cc's is not a lot, an awful lot of blood. But here comes the critical part. Over the ensuing 4 hours, he continues to drain between 200 and 300 cc's of blood per hour. Now this is adding up to a lot of blood. This is not coming from the lung. This patient also has a systemic vessel. Again, probably an intercostal. He will need a thoracotomy. And in fact, he's clearly in need for a thoracotomy, because if you read what the books say about this, they say if it adds up to 600 cc's in the next 6 hours, that's a good enough reason to go in, 100 cc's every hour. So this one needs the thoracotomy. Well, we talked about pneumothorax, talked about hemothorax. Of course, both could coexist. Vignette number 7, a 25-year-old man is stabbed in the right chest. He's moderately short of breath, has stable vital signs. No breath sounds on the right. Is hyperresonant to percussion at the apex of the right chest, dull at the base. And the chest X-ray shows one single large air fluid level. You got blood at the bottom, you have air at the top. And we need to manage each of the two conditions. We need to get rid of the air, we need to get rid of the blood. Again, we're going to begin with chest tube. And here, some people would put 2 chest tubes. One at the top to take care of the air, one at the bottom to take care of the blood. There are others who would say we can put a tube at the bottom, we push it all the way up to the top, the tube has holes at multiple levels, so it drains both the air and the blood. And I don't think that's a terribly important issue. They will offer you only one of those 2 potential correct answers. But let me point out, because we're going to see another vignette a little later on, the significance of that single large air fluid level. Because if what you see in a trauma patient is multiple air fluid levels in the chest, that probably means bowels up in the chest. So this is one single large air fluid level. All right. Now in the next vignette, we have a clinical condition that we should be able to recognize. And I think the challenge will be for us to understand how did it happen, and that should be easy too. A 33-year-old woman is involved in a high-speed automobile collision. She arrives at the ER gasping for breath, cyanotic at the lips, with flaring nostrils. There are bruises over both sides of the chest and tenderness suggestive of multiple rib fractures. Blood pressure is 60/45. Pulse rate is 160, feeble. She has distended neck and forehead veins, is diaphoretic. The left hemithorax has no breath sounds. It is hyperresonant to percussion. Here's a trauma victim who's gone into shock, who has big distended veins, and who's got trouble breathing, and no breath sounds on one side. And we already visited that issue a little earlier, and that is a tension pneumothorax. But you say, wait a minute, where is the penetrating injury? It's right there. Multiple rib fractures. And remember, we made the point that the jagged edges of broken ribs can in fact become a penetrating weapon as they are driven into the patient. This patient has a tension pneumo, and she needs, of course, a needle to that side of the chest that is full of air, followed by a chest tube. But she's going to need more, because actually this vignette is our introduction now to blunt trauma to the chest. And I need to go into a rather extensive background information here. When we have a question on the exam that gives us blunt trauma to the chest, and this is major, okay, big time blunt trauma to the chest, there are three issues that we have to pay attention to. There may be an obvious injury. In this case, it was a tension pneumothorax. But in addition to that obvious injury, there are a couple of injuries in the chest due to severe blunt trauma that may not show up right away, but show up later. And therefore, we have to monitor for them. They include pulmonary contusion and myocardial contusion. So this particular case that we already read, we know the immediate therapy is a needle to the chest and the chest tube because we have to deal with that obvious tension pneumothorax she has. But over the ensuing day or two, we're going to be repeating chest x-rays and doing blood gases to identify pulmonary contusion should it become obvious later. And we're also going to be doing EKGs and perhaps cardiac enzymes to identify myocardial contusion in case it doesn't show up until later. But that's not the end of it. There is also the possibility in severe deceleration injuries of a hidden injury that doesn't show up at the beginning and will not show up until the patient suddenly dies. And therefore we have to actively look for it. And that is the famous traumatic transection of the aorta. Let's remind ourselves what this is all about. If a patient is going at 30 miles an hour or 50 miles an hour and comes to a sudden stop, at that moment of a deceleration, the arch of the aorta, which is free to move, keeps going forward, but the descending aorta, which is fixed, doesn't. And at the junction of the two, the aorta can crack. Now you might be thinking, well, if the aorta cracked in two, the patient is going to exsanguinate at the site, and indeed that often happens. But that patient will die at the scene of the accident. That patient will not make it to the hospital, and that patient will not make it to the USMLE, because the USMLE doesn't deal with dead people. But there is a subset of patients that get the traumatic transection of the aorta, that have a transection of the intima, have a transection of the media, but the adventitia stays intact. A big hematoma forms, but it is contained. That patient may be completely asymptomatic, but that adventitia cannot hold, the pounding of arterial pressure very long. A few hours later, that is going to blow, and the patient is going to die. So any question on the exam where a patient has suffered severe deceleration injury with chest trauma, we have to actively look for a traumatic transection of the aorta. Let me tell you how we do that. The first thing we do is we look in the chest x-ray, which is always one of the first things that a patient like this gets, to see if there is a wide mediastinum. The chest x-ray shows a wide mediastinum. We have a very high index of suspicion that the patient may have a traumatic transection of the aorta. We don't know that that's the case. The wide mediastinum is not diagnostic. Neither is, for that matter, the absence of a wide mediastinum sufficient to rule it out. But the wide mediastinum tells us this is very likely to be the case. The next thing we do is a spiral CT scan of the chest. Spiral CT scan is a high-quality, high-definition, very elegant CT scan that gives us cuts at very close to one another with a great deal of detail. That spiral CT scan may, in fact, be able to establish a diagnosis and show us, yes, the patient has a traumatic transection of the aorta, and then the repair is done immediately. But if that spiral CT scan is negative, we know that the spiral CT scan is not 100% diagnostic. If we had the wide mediastinum to begin with, and then we have a negative spiral CT scan, we're not going to quit there. We're going to keep moving to a more aggressive study, we would do an arteriogram and a aortogram to be sure that the patient does or doesn't have the traumatic transection of the aorta. On the other hand, if a patient doesn't have the wide mediastinum to begin with, and now we don't have a high index of suspicion, we're not going to quit, we're going to do the spiral CT, but that will be as far as we go. So if that spiral CT and the patient who didn't have the wide mediastinum is negative, we quit at that point, and we do not feel compelled to continue with a more invasive and more risky arteriogram. All right? Well, let's move on to the next vignette, and we're going to have this issue come up time and time again. Vignette number 9. A worker has been injured at an explosion in a factory. He has multiple cuts and lacerations from flying debris, and is obviously short of breath. The paramedics at the scene of the accident ascertained that he has a large flap-like wound in the chest wall, about 5 cm in diameter, and he sucks air through it with every inspiratory effort. This is actually a special kind of injury. It's included here because the first aid is a very important facet of it. When you have that flap-like wound, and as the paramedics are looking at the patient, they can see that with inspiration, air goes in. But with expiration, the flap closes and the air stays in. This is a patient who, left alone, is going to develop a tension pneumothorax. This is a classical sucking chest wound. And so this patient needs to have an occlusive dressing put over that wound. A good way to do this would be a big dressing of Vaseline gauze that sticks to that chest wall, that prevents the air from going in when the patient inhales. But a little elegant detail that may identify the best answer on the exam is that dressing gets taped on 3 sides rather than 4. So when the patient might push and expel some of the air out during expiration, the air can find a way out because you lift both the flap and the chest wall, and you lift that flap that was left untaped on one side of the dressing. All right, let's move on to the next one. Vignette 10. A 55-year-old woman crashes her car against a telephone pole at high speed. On arrival at the ER, she's in moderate respiratory distress. She has multiple bruises over the chest and multiple sites of point tenderness over the ribs. X-rays show multiple rib fractures on both sides. On closer observation, it is noted that a segment of the chest wall on the left side caves in when she inhales and bulges out when she exhales. Now, this is not a loose fragment like the previous one. This is not a sucking wound of the chest. There is still an intact skin, but the ribs are damaged underneath, and the chest wall has lost the stiff integrity that it normally has. And in fact, you should have already recognized that this is a physical finding that we call paradoxical breathing, leading to the diagnosis of a clinical entity that we call flail chest. So let's go back to our thinking here. This lady had big, blunt chest trauma. She may have an obvious injury. She may have the injuries that don't show up until later. She may have the injury you have to look for. The obvious injury at this time is a flail chest. Now, what do we have to do about the flail chest? At one time we used to think that the problem in the flail chest was mechanical. It had to do with the fact that that piece of the chest wall wasn't moving the right way. And so when that was the feeling, the treatment was directed at that piece of the chest wall. We used to put traction to it, hang pulleys and weights from the chest wall, maybe wire the ribs together or tape them or something. And we now recognize that, in fact, even though the chest wall is moving in a funny way, that in itself isn't affecting much the respiration of the patient. If this patient is in respiratory distress, that is because she has also suffered pulmonary contusion underneath those broken ribs. So in reality, the treatment for the flail chest is the treatment of the underlying pulmonary contusion. Now, contused lung is very sensitive to fluid overload. So part of the therapy for the contused lung, and therefore therapy for the flail chest, is fluid restriction, perhaps diuretics. If fluids are needed because of other problems of the trauma, we prefer colloid rather than crystalloid. That is a fluid that will have protein in it that will make it stay in the vascular tree more than leak into the lung parenchyma. But perhaps even more important than that, the treatment for pulmonary contusion is the treatment for the ensuing pulmonary failure. And that will be evidence that will be measured by blood gases. So the management on this patient, we have to make sure we don't overload her with fluids because she's at high risk for pulmonary edema. So we need fluid restriction, perhaps the use of diuretics, and then monitoring blood gases. If those blood gases begin to deteriorate, PO2 is going down, PCO2 is going up, this lady will need to be intubated and placed on a respirator so that the machine breathes for her. But there is a very important detail. If this patient needs a respirator because of a flailed chest, we have to keep in mind that she's got multiple broken ribs that may have punctured the lung. As long as she's breathing on her own, those little puncture sites may not be a problem. But once she's intubated, and once there is positive pressure going into her tracheobronchial tree, those puncture sites may leak air, and she may develop a tension pneumothorax, either on one side or the other, depending on where the broken ribs are. So she, if she's going to go on a respirator, needs a chest tube on that side where the broken ribs are. And if there are broken ribs on both sides, she may need chest tubes on both sides. But we're not done yet with the management of this patient. We've taken care of the obvious injury, the flailed chest. We still have to monitor for the other ones. We're already taking care of pulmonary contusion because that's the treatment for the flailed chest. We need to monitor EKG, cardiac enzymes, in case she develops signs of myocardial contusion. And we have to look for the traumatic transectional aorta. So on that chest X-ray, I'm going to say it again. On that chest X-ray that has already been taken, we need to see there is a wide mediastinum. We're going to follow that with a spiral CT scan. Whether there was a wide mediastinum or not, we're going to do the spiral CT. But if there was a wide mediastinum and the spiral CT is negative, we're going to continue with an arteriogram. All right, let's move on. Opinion number 11. A 55-year-old woman crashes her car against a telephone pole at high speed. On arrival at the ER, she's breathing well. She has multiple bruises over the chest and multiple sites of point tenderness over the ribs. X-rays show multiple rib fractures on both sides, but the lung parenchyma is clear and both lungs are expanded. So at this time, we have no reason to be intervening for her breathing. She's breathing on her own, the lungs are expanded, but we are mindful of the fact that she could show up pulmonary contusion at a later time. We're mindful of the fact she could show up myocardial contusion at a later time. And so the vignette now goes on. 2 days later, her lungs white out on X-rays, and she's in respiratory distress. So the follow-up here shows 1 or 2 days later that she's developing the signs of a pulmonary contusion. If they had not been monitored already, she now needs blood gases because we need to determine if she may need to go on a respirator. And she may need now the fluid restriction and the diuretics, all of the management that we mentioned before. Here's another reminder of this, vignette 12. 54-year-old woman crashes her car against a telephone pole at high speed. On arrival at the ER, she's breathing well. She has multiple bruises over the chest and is exquisitely tender over the sternum, at a point where there is a gritty feeling of bone grating on bone, elicited by palpation. That's a clinical description of a fracture of the sternum. That's significant chest trauma, what lies right beneath the sternum, the heart. If this lady doesn't have signs of myocardial contusion right now, she may develop them in the near future. So here's an example of a lady that is going to need EKG monitoring and cardiac enzymes because she may show up with signs of myocardial contusion. Incidentally, we treat myocardial contusion very similar to the way we treat an MI, except we do not use clot busters because that's not the problem. But, we treat all the complications as you would treat the complications of an MI. You should also be actively looking on this lady for the traumatic transection of the aorta. And in fact, let me use this vignette to make another interesting point. I've been talking about how when there is big, gigantic chest trauma, blunt trauma, that we have to worry not only about the obvious injury, but the ones that could show up later and the one that could never show up until the patient dies, which is a traumatic transection of the aorta. Now, we may have evidence on the vignette that the trauma was a significant magnitude. The vignette may say it was a car accident at 50 miles an hour. In fact, there is another clue, very favorite one of people who write questions. The lady was in a car accident. 3 of the 4 people that were in the car were dead at the site. She's the only survivor. Well, that means that was a big crash. But there are 3 other clues that I want to alert you to. There are 3 bones in the chest that are very hard to break. The sternum, the first rib, and the scapula. So any exam question that tells you blunt trauma to the chest, there is a sternal fracture. Or blunt trauma to the chest, there is a fracture of the first rib. Or blunt trauma to the chest, there is a fracture of the scapula. They are telegraphing you in code. Look, this was a big, enormous, gigantic trauma. Because you don't break those bones by falling off your tricycle. Okay? All right, let's move on. Vignette number 13. So we pointed out, let me go back up to 12 for a second. Pointed out then that because this is big trauma, we need to look for the traumatic transection of the aorta. You know how to do that. Okay, vignette number 13. A 53-year-old man is involved in a high-speed automobile collision. He has moderate respiratory distress. Physical exam shows no breath sounds over the entire left chest. Percussion is unremarkable. Chest X-ray shows multiple air fluid levels in the left chest. You remember this one from early on? No, this man doesn't have multiple little hemothoraces and pneumothoraces on top. If you have multiple air fluid levels, that's bowel up in the chest. And the mechanism of injury here is a traumatic rupture of the diaphragm, which incidentally is always on the left side. The right side has that big, gigantic liver between the belly and the chest, and you don't get the chest full of bowel on the right side. So this is a traumatic diaphragmatic rupture. It's always on the left. It needs surgical correction, which is done from the abdomen typically. You might have an additional little clue here. They may tell you that an nasogastric tube was placed and the tip of the tube curls up into the chest. Well, then it's even more obvious, but you don't really need that. All right, let's move on to vignette number 14. A motorcycle daredevil attempts to jump over the 12 fountains in front of Caesar's Palace Hotel in Las Vegas. This is an actual case that happened. As he leaves the ramp at a very high speed, his motorcycle turns sideways, and he hits the retaining wall at the other end, literally like a rag doll. At the ER, he is found to be remarkably stable, although he has multiple extremity fractures. The chest X-ray shows fractures of the left first rib and widened mediastinum. Now, the clues are all over the place. You already know this is big-time trauma because you're given the circumstances, a motorcycle at high speed. But if that didn't register, you're being told the first rib is broken, and that immediately says to you this is big-time trauma. And then you're told that same X-ray shows a widened mediastinum. And the meaning of that is this is very likely a traumatic transection of the aorta. And even though this patient is relatively asymptomatic as far as the chest is concerned, we got to go look for that injury. In fact, when this real case happened, this was in fact a gentleman who had a traumatic transection of the aorta. This was in the days when the only way to diagnose that was with an arteriogram. Nowadays, we don't need to begin with the arteriogram, we begin with a spiral CT. If it is positive, move on to the repair. But if it were negative, then push on and do the arteriogram because, you have a very high index of suspicion that the traumatic transection of the aorta has occurred here. All right. We move now to vignette number 15. A 34-year-old woman suffers severe blunt trauma in a car accident. She has multiple injuries to her extremities, head trauma, and pneumothorax on the left. Shortly after initial examination, it is noted that she's developing progressive subcutaneous emphysema all over her upper chest and lower neck. We visited this briefly at the very beginning of the review when we mentioned that this is one of the reasons why we need an airway. But let's review now what other circumstances that may lead to air bubbling up into the lower neck and upper chest. There are three. We can see that happen when there is a perforation of the esophagus. But the setting would be completely different. The setting would be the patient had an endoscopy and shortly thereafter has air. The second possibility is a tension pneumothorax, actually. But we didn't even mention this when we're talking about tension pneumothorax, because in tension pneumothorax, there are many other things far more impressive and alarming. The patient is in shock, the patient is in respiratory distress, the patient has big distended veins. You're not going to have a patient who's just smiling at you with air in the neck and be a tension pneumothorax. And the third possibility, what this one is a major tracheobronchial injury. The trachea is ripped in two or a major bronchus is ripped in two. So this patient needs fiber optic bronchoscopy, both as the way to guide the insertion of an airway and as a way to confirm the diagnosis and then surgical repair after that. Let me point out that sometimes a major tracheobronchial injury is not obvious at the beginning. The patient may not come with the air in the neck. There's another way then to suspect them, vignette number 16. A patient who had received a chest tube for a traumatic pneumothorax is noted to be putting out a very large amount of air through the tube. This is what the chest surgeons call a large air leak. And his collapsed lung is not expanding. That's another indication of a major bronchial injury. When we have a pneumothorax and we put a chest tube and we put it to suction, typically the lung expands, and within a few days there is no more air leaking from the lung, and that's the end of that. If the lung doesn't expand, and there's an enormous amount of air coming from that tube, that air is coming through that big bronchial injury right from the lung. And so this is another indication then for the fiber optic bronchoscopy and the surgical repair. Vignette number 17, this is a pretty rare one, but we should be able to identify it. A patient who sustained a penetrating injury of the chest has been intubated and placed on a respirator, and the chest tube has been placed on the appropriate pleural cavity. The patient had been hemodynamically stable throughout, and then suddenly goes into cardiac arrest. You know, when people die from trauma, because they are bleeding or because they have a tension pneumothorax, we know they are going to die. In other words, there is a deterioration of vital signs. We realize that we're losing the patient. The trauma patient who dies is not a person who's smiling and talking to you and suddenly drops dead. Even the traumatic transection of the aorta, when it blows out, the patient goes into shock and then dies. When we see sudden death, like you turn on a switch, in a trauma patient, think of air embolism. Air embolism can do it. And in fact, the mechanism in this case, there was an injury to a major bronchus and to a major vessel next to one another. As long as the patient was breathing on his own, there was no pressure within the airway, nothing happened. Once the patient is on a respirator and air is being blown into that lung, that air leaks out, gets into that major vessel that is nearby, gets into the atria, gets into the ventricle, and you get the sudden cardiac arrest of the air embolism. Actually, there are other circumstances that might make for an easier setting to lead to this. I have two more vignettes that will exemplify this. Vignette number 18. During the performance of a supraclavicular node biopsy under local anesthesia, suddenly a hissing sound is heard and the patient drops dead. Vignette number 19. A patient who's receiving total parenteral nutrition through a central venous line becomes frustrated because the nurses are not answering his call button, so he gets up and out of bed, disconnects his central line from the IV tubing, and with the open catheter dangling, he takes 2 steps in the direction of a nurse's station and drops dead. You have here 2 examples where a major vein near the superior vena cava becomes open to the air in a patient who's awake. One was a supraclavicular node biopsy under local anesthesia, the other one is a patient with a central line. And if that happens, and it happens at the moment when the patient is inhaling rather than exhaling, and there is negative pressure in the chest, it may suck enough air through that either surgical injury of a vessel in the first example or the open catheter on the second to get enough air into the ventricle, that would be about 120 cc's, to make the foam that stops the heart immediately. In either of these cases, we put the patient in Trendelenburg. We put them with the left side down, right side up, hoping the air stays in the atrium rather than the ventricle. If you have the tube in place, like the patient with the central line, we try to suck the air out of there. We obviously do cardiac massage and attempt resuscitation. Many of these patients die, however. And the last vignette that we have on the chest trauma is actually not chest trauma. I included it here because the manifestations appear to be those of chest trauma. Vignette number 20. A patient who sustains severe blunt trauma, including multiple fractures of lung bones, becomes disoriented about 12 hours after admission. Shortly thereafter, he develops petechial rashes in the axilla and neck, fever, and tachycardia. A few hours later, he has a full-blown picture of respiratory distress with hypoxemia. Chest X-ray shows bilateral patchy infiltrate and his platelet count is low. This is actually fat embolism. What identifies that is multiple lung bone fractures followed within a few hours by respiratory distress. Now you have a host of other details here, the petechial hemorrhages and so on. But if you simply have multiple long bone fractures and a few hours later a low PO2, the respiratory distress, that is fat embolism. We used to think at one time that we had specific therapy for fat embolism. We used to use intravenous heparin or alcohol or low molecular weight dextran. So it used to be essential for us to confirm the diagnosis. We would look for fat droplets in the fundus of the eye, or, but we now realize that in fact the only thing that works in a patient who has fat embolism, the only thing the patient needs is respiratory support. That low PO2 is crying for intubation and a respirator, and that's what we do. And so once we diagnose that the patient has the hypoxemia that this patient needs respiratory support. And it makes no difference whether you have the rest of the picture or not. So if the question on this vignette on the exam is what is the diagnosis, when you put together the multiple lung bone fractures and the subsequent respiratory distress, the answer is fat embolism. But if the question is management, the management revolves around monitoring of blood gases and respiratory support as needed. And that wraps up then the chest vignettes, and the next chapter then will deal with abdominal trauma.